That's working. That's working.
Great.
Are you okay with? Or you want me to come up when your video runs just to minimize this and click on it?
If I have a problem, you'll know.
Okay.
Very quickly.
Do you know where it is though? And I mean, all you're gonna have to do is this, minimize it, and then you can bring up the video as here.
Oh, okay, super. Thank you for
So
telling
you
me.
would click on that.
And then it will go back. Okay. Oh, and it didn't even change the screen.
Let's see if it actually.
Yeah.
I mean, can I test it real quick? Just to,
No.
No. You don't want to. I don't think you have to actually close this out.
If I do, I'll
You might have to close this and then click on it and then reopen it, but
I can minimize it, I guess.
yeah.
And how do I get back to the speaker view? Because
To
now
the-
it looks different.
Yep. Just click on this.
Oh, yeah.
Why is it not liking that?
Oh, there. Just do that.
Why the heck doesn't it like that? Let's just close it out and reopen it. Yeah, cancel that. Now go on to that. What is going on?
Oh, I know. You
the
have to
stupid
close that
thing.
thing.
Yeah. All right.
There.
There you go.
Good morning.
Hi.
Yes, how are you?
Ann.
I am supposed to introduce you,
Okay.
and I'll turn it over to you.
Great.
And
Should
then,
I sit somewhere or just stand right here?
You s- stand up there.
Yeah.
And then, hour and 15 minutes, if you're running up close to the time, I'll let you know, if it's 10 minutes or that kind of thing. Certainly want to leave it open for some questions, I would think, so.
I'm going to just set my timer.
Got a presentation?
So it's 30 slides, and usually it's about 45 to an hour, depending on how I get going.
Okay.
I think I will not have questions until I get to it.
Okay.
So,
I can mention that as well. And then, and it's Newmeyer, right? So
Yeah.
you pronounce that?
yeah,
Okay.
yeah, yeah.
So then, screw that up at all.
Okay. Actually, I'll pause that. So this way, and this way I have 20 minutes per session.
Okay. And we have, one other person will be in the back of the microphone, so they'll be running back and forth with the microphone for questions.
Perfect.
That way, and then, at the end, I just have a few things to say. On our app, we have a critique for the session and some other housekeeping things. I need just like 30 seconds at the very end before we let them go.
Okay. Perfect.
Okay?
Yeah.
Good.
Thanks for doing this.
Oh, no problem. Thank you for coming. We appreciate it.
Oh, yeah, it's really, actually, it's a fun meeting.
Yeah. Have you been to,
It's my first one.
you have your first time
No, you know what? I
attending?
didn't get any of those little,
Oh, you should get a speaker. I can get you a couple of them. It's always nice to have, a couple, three.
yeah. I was thinking I should put volunteer also. That's where all the volunteers.
Good morning. Can someone get a couple of the doors, I guess, there, just as we get started? There's just some noise there in the hallway. So this session is called Behaviors and Regression in PMS. And Dr. Ann Newmeyer will be our presenter today. She's a child neurologist, assistant professor of neurology at Harvard Medical School, and medical director of the Lurie Center for Autism. Sorry, lost my place here. She has a passion and expertise in the diagnosis and treatment of children with neurodevelopmental disabilities such as autism, more specifically in medical and neurological issues that present with autism. So without further ado, I present to you Dr. Ann Newmeyer.
Set my timer so I don't overspeak. So thank you for having me here. It's a pleasure to speak with you. And I just want to say I got a little bit nervous when I heard that the dogs were next door because I thought everyone would be there. So I'm happy you came to my talk. So I'm going to talk about behaviors and regression and behavioral regressions. And it's a little bit different from the talk that Dr. John Bernstein gave yesterday, because I'm going to be more practical, kind of down and dirty, and just talk about what the behaviors are and what that can mean, and things for you to look out for and how you can advocate with your caretakers and physicians. So I'm going to start with, so you guys were polled, I think, before the meeting and asked your top 3 questions or concerns about your child's regression, I guess. And the 3 questions that came up were, what are the causes of regression? What is regression in behaviors? What do we know in PMS and medical psychiatric causes? So I'm going to talk about that. And then what are some treatment options and how do I prevent regression? So I'm going to try to talk about that. And I think that we're going to go over, I think that's a double slide. Oh, so we're going to talk about first behaviors and regression, and then what do we know about them in PMS, and expression of pain in minimally verbal children and adults, and then go over some of the medical issues that we see that cause regressions, and some of the psychiatric issues we'll touch upon. So some of this is what you've heard with John Bernstein yesterday. True developmental regressions often involve loss of milestones, loss of language, or activities of daily living. And they can involve motor skills that are being lost, toileting skills that are being lost, language skills, and changes of behaviors that we can see can be self-stimulatory or repetitive behaviors that increase, echolalia that increases, or aggression or self-injury. Also being withdrawn, we see that often as a change of behavior. And one of the things that I think is important is that when a child has a regression, sometimes there's small things that you start to notice, and when you start to notice those things that the child is losing, I think it's really important that you comment on it and you seek help early, because many of the times it's something small that might, or easily treatable, that might be going on. And sometimes it's something bigger and harder to treat, but it's always better to seek help earlier when the treatment might be easier. And I'll tell you about some of the things I've seen over the years. I've been caring for children with autism and developmental disabilities for 25 years now, so I've seen a lot of things that I wish I hadn't. So you guys were also surveyed about regression, and 46 of you or 68%, 63% responded that their child had experienced a regression, and 22% responded that their child hadn't. From reading or from the literature, we know that about half the parents report regression in PMS. And the age of regression is a little different than in autism. Children with autism, about a third of them present with a regression under the age of 3. And in PMS, about 43% presented before the age of 2.5. But the median age was much older, so that was almost 5 years old. Boys more than girls present with regression in PMS. And in one of the studies that was done by Ryerson in 2017, 6 out of 18 were associated with medical issues. If I use a word that you don't understand, because I sometimes forget and use medical language, then just raise your hand so I know, and I'll use a different term that might be understandable, so, because I want to make sure you all understand. And then 3 out of 18 were associated with neurological issues or seizures. So from the literature, we know that what is lost are motor skills, 59%, self-help skills, 53%, language skills, 14%. Social intent is lost in a third of the girls that had a regression, more so than the boys. Purposeful hand movements were about 29%, and play skills were lost more in the girls than in the boys. That might be because the girls had more play skills to start with. I don't know. So you also answered a question about behaviors. Some of the behaviors that affected the child and the family's quality of life. Those behaviors included wandering, aggression, screaming, flopping on the ground, inappropriate laughing, eating non-food items, or pica, excessive chewing, withdrawal, jumping, flapping, and self-injurious behaviors. So in my world, where I see children with autism and PMS, we see a lot of these behaviors that get worse when the child is sick or stressed or anxious or depressed, and the behaviors get better when they're feeling better. So one of my goals today is to help you to recognize that, so that the doctors don't say, oh, well, they have autism or they have PMS and that's it, because I think that you can make things better just by treating the whole child and making sure they're well. So the next thing we're going to do is talk about pain, and then I'm going to go over some of the medical issues, sleep, gastrointestinal issues, seizures, and other issues that are seen in PMS. And then we'll talk about psychiatric issues a bit, but I'm a neurologist, so. So for pain expression, you got 72 people responded to the survey when they were asked how your child lets you know that she or he is in pain, and 21 of you responded with cry, 10 said doesn't let me know, and 6 said that they recognize that their child will say a particular phrase when their child is in pain. So 8 respondents also said that they know their child has a very high tolerance for pain, and that we see that pretty frequently. So pain looks different in every child, and every child expresses it differently, and many nonverbal children will express their pain nonverbally. And we know 75% of children with PMS have impaired communication. And again, as I said before, sometimes it just looks like the child is more autistic. So I have Mickey there because you have to be a detective to try to figure it out. And watching the child and how they're moving and what they're doing can often give us very important clues to understanding where the pain is, or what they're doing, which might be trying to relieve the pain. So I'm just going to go over some of the things that we see that are expressions of pain. Screaming, verbal tics, throat clearing and swallowing can be a sign of pain. So if a child has strep throat or they have reflux, they might be just clearing their throat a lot. They might want to drink more, they might want to drink less because of their pain. So echolalia, or scripted speech, repeating the same phrase, referring to a body part or to the doctors or to pain, might be the sign that they actually are sick or have pain. Moaning, sobbing, and crying without reason, that kind of makes sense. And sometimes aggressive vocalizations also are a sign of pain. So if there's a sudden change and the child is having aggressive vocalizations, then that might be a sign that they're actually hurting and they're just feeling irritable. So expression of pain with body movement. So we have a couple pictures here. Facial expressions, dystonia. So dystonia is when you have a kind of a movement and it might involve twisting the head or looking stiff. That can be an expression of pain. Mouthing objects is really common, especially in kids. And we all know babies, when they are teething, they mouth objects. And for people who can't communicate, they may start mouthing when they're having dental pain, sometimes earaches also. Gait changes, posture changes. We had a little girl who had appendicitis, and she stopped walking. And we didn't know that that was why she stopped walking, and so everyone did x-rays of the legs and x-rays of the hips, and then a very smart ultrasound technician was looking at her hips with an ultrasound, and she maybe had a little ADD, and she wandered into the belly and saw that there was an appendicitis there. So once that was fixed, she was walking again, but the child couldn't tell us that she had belly pain. So we take these things very seriously. Posture changes can be a sign of pain, tics, and then dyskinesias. So Sandifer syndrome is when little babies have reflux and they arch their backs and they twist their head, and it's what we call a dystonia or a dyskinesia, an abnormal movement. And what we see is that older children who are nonverbal also develop this movement disorder, and it's just reflux. They're just having gastroesophageal reflux, and it's hurting them, and so they're turning their head or twisting to make the pain better. But they're not telling us that's what they're doing, and so it looks like they have a neurological disorder. So they go to a neurologist, and the neurologist has to recognize that it can happen in older children also, otherwise it gets missed. So other expressions of pain, irritability, sleep disorders are really important to think about, that they're caused by pain. If a child has been sleeping and starts waking up at night, you have to think about pain as a reason for that. Non-compliance, self-injurious behaviors. Oh, and then appetite. I don't know why I wrote sleep twice. Okay, sleep. It's a problem for the parents, and it's also a problem for the individuals with PMS. And we know that sleep is not formally evaluated in enough children with PMS. Only 22% have had formal sleep evaluations in a study that was done in the past year. And children with PMS have difficulties falling asleep, staying asleep, and waking up early. I think you probably all know this. Reasons for that. So like in autism, the core deficits of having anxiety and behavior and wanting to have a routine are part of the issue. In children with autism, we know that the melatonin levels are lower, and I don't know that there's been a study looking at this in children with PMS, so I just don't know, but sometimes melatonin works, so maybe that's part of the problem. And then again, a lot of children have other comorbid or other concurrent illnesses that can affect sleep, like GI. If you have reflux and you lie down, the reflux gets worse. Or if you have epilepsy, that can impair your sleep. Pain can make it worse, and other medical or psychiatric or neurological disorders. And anxiety is a big issue. So again, if your child's having sleep problems, look for an underlying cause. So how do we treat sleep problems? One of the most important things is establishing a really good sleep routine, which is often not a hard thing to do, but making sure that the temperature is right, the clothing textures are right for the child. I have a picture here. Let's see if this works. This is a picture schedule showing a different routine for sleep. if the child reads, maybe you can do just a written schedule. And it's always good to adhere to the schedule. ATN also has, the Autism Treatment Network has online a toolkit for helping your child with autism sleep, and they have a lot of good information there also about sleep. Probably the most important thing is teaching your child to fall asleep in bed, because a lot of parents have such sleep issues that they end up carrying their child around or sleeping with them on the couch or helping them to fall asleep on the couch in front of the TV. And the thing is that how the child falls asleep the first time during the night is how they're going to fall asleep the second and third, because we all wake up a couple times during the night. So if they don't fall asleep alone in a bed the first time, then they're going to want to fall asleep the same way the second time. They're going to want to fall asleep with the parent rubbing their back or lying next to them in bed. So, you know, trot, trot, trot down the hallway back into the parent's bed at 1 in the morning or at 2 or 3. Or they'll get anxious and then wake up because they don't know how to fall asleep again because their mother's not there rubbing their back the way they did it the first time. So learning to fall asleep alone is really important. That is, if you don't, and in some families and in some cultures, parents sleep with their kids, and then that's fine. But if you want to sleep alone through the night, then you have to teach your child to learn how to fall asleep alone the first time. So it's hard because they have to learn how to fall asleep alone, but once they learn, they've learned a skill, and that's really important. And then they'll be able to fall asleep and hopefully stay asleep. So the other thing is it's important to try to avoid napping in older children and adults, and again, start to sleep in the bed, not on the couch. And there are a lot of things you can do to improve sleep, like exercising during the day, going out for walks. That's good for parents too. And then rewarding good behaviors. So this is a bedtime pass, and that works for some kids who don't have a lot of anxiety about sleep. You give them a pass at nighttime, and the kid keeps it with them, and if they come into your room during the night, then you take the pass away. But if they don't come into your room in the morning, they get to redeem it for a small treat. So I think you all know, but small treats that are immediate work really well, and big prizes are meaningless, usually. So some kids, as they get older, they respond well to earning a prize, which is great, but a lot of children, they just need an immediate reward. So, like promising Disney doesn't work for sleep. And then ensuring there are no medications which impair sleep, and that includes anything with caffeine, so no sodas at all during the day that have caffeine in them, or iced tea down here. And then some medicines that can help with sleep. Melatonin, I give between half and 9 or 10 milligrams at night to a child, and I generally say start with a half or 1 milligram, and then just every 2 or 3 nights increase it up until you get 10 milligrams, and if it's not working, then you tried. The thing about melatonin is it lasts about 4 hours in your system usually, and so if it helps you fall asleep, but it doesn't help you stay asleep. So if your child wakes up at 1 or 2 in the morning, they're still going to wake up at 1 or 2 in the morning, unless the melatonin is helping them to learn how to fall asleep the first time more easily, because then sometimes that can just help them to learn how to fall asleep, and so then it's easier for them to fall asleep, and then they stay asleep. So sometimes it does work to help a kid fall asleep through the night, but we know that how the melatonin works and lasts, that it typically won't help them stay asleep. The other important thing is that there is long-acting forms of melatonin, but those are all non-chewable pills. So the child has to be able to swallow a pill. Let's see. So the rest of the medicines that I'm going to talk about are things you have to get from the doctor. So clonidine is a blood pressure medicine, and that, just like melatonin, helps kids to fall asleep but not stay asleep. It lasts about 4 hours in the system. And there is a long-acting, but again, it's a pill, so you have to be able to swallow the pill. Guanfacine is another blood pressure medicine that makes children tired, and again, you need to swallow the pill for the long-acting. So trazodone is another medication that it was originally prescribed as an antidepressant, and everyone who took it would fall asleep. It made them so tired. And so what we do now is we prescribe it as a sleep medicine. And that is one medicine that works great to keep kids asleep through the night. So the 3, 4, 5-year-old who's never slept through the night, we can put them on trazodone, give them trazodone, and then the child sleeps through the night, the family sleeps through the night, and it's a godsend. There are some negatives with trazodone, like in adolescent and post-adolescent boys and men, it can cause sustained erections, which can be dangerous. But for prepubertal children, we don't have that problem. So mirtazapine is another antidepressant, anti-anxiety medicine that works very well for sleep, and it makes children tired and decreases anxiety, and there's a lot of anxiety in children about falling to sleep. And the biggest side effect of that is it makes you hungry and eat more. And sometimes that can work very well for a family, but adolescent girls hate it. So amitriptyline is another medicine that sometimes can work well for sleep. And then diphenhydramine, that's Benadryl. So that's also short-acting, and sometimes it works great, but I always tell families, try it out once during the day, because some children, it activates them. It makes them, they get the paradoxical reaction, and they go crazy. I mean, they just get very activated, like they had 5 cups of coffee. So if you've tried it once and you know it makes them sleepy, then it's very nice to have, especially if you're going away and you need you need them to get sleepy. And then the benzodiazepines like Valium, Ativan, those can be useful sometimes for going to sleep. I typically don't like prescribing them. And the problem is in children, they can also be activating so that the child appears more anxious and gets revved up. And again, treating whatever the underlying disease is can also be very important. Like remember, ear infections keep kids up. And they may not tell you they have an ear infection, but if you treat the underlying infection, then they're going to start sleeping again. So epilepsy. So we know that epilepsy doesn't, so what we've read, and from the study that Dr. Bernstein was talking about yesterday, we know that epilepsy doesn't predict regressions. And we also know that abnormal EEGs don't predict regressions, but they do predict seizures. So that said, my experience is that children who have epilepsy tend to have more autistic behaviors. They have worse motor skills, attention, self-injurious behaviors in children who have an intellectual disability and non-intellectual disability. And we know seizures are common in PMS. So when I have a child who's getting irritable or isn't sleeping at night, and it's a newer thing, it's a change, then sometimes I'll do an overnight EEG. Because there is a form of epilepsy where you don't see the seizures during the day, but the child is having seizures at night. And so if a child is losing skills, then we'll do an overnight EEG. And sometimes we can do them out of the hospital. But generally speaking, the amount of electrodes that they put on the head aren't as many as they do in the hospital, so it's not always as good a study, but often it's the step one before we do an in-hospital EEG. It's really hard to do an EEG in a child that isn't so willing to have the leads placed on their head. So I can recommend the Autism Treatment Network has a toolkit. So if you type toolkit, Autism Treatment Network, or Autism Speaks EEG, there's a really nice guide to doing an EEG in a child with autism or intellectual disability. And they also have information for the EEG technicians there. So some EEG technicians are willing to read it and learn so that they can help the child. And they also go through like a little social story for a child and have pictures, which can be very helpful. So we heard talks about gastrointestinal disease. Back in 2006 at the meeting, you were asked how much do GI issues negatively cause belly pain? And you responded that 51% of the time occasionally and 19% often. So a lot of kids have constipation, and I think that can really impact children quite a lot. 40% have constipation or diarrhea, 85% of individuals have pica or putting non-food items into their mouth. 42% of individuals have gastroesophageal reflux disease. Only 24% of individuals with PMS are toilet trained. And then there was a zebrafish poster yesterday morning that talked about all sorts of abnormalities that they see in the zebrafish who have the genetic change of PMS, so that they engineered. And I don't know if, so maybe that translates to humans also, but we know clinically it does, that the children have a lot of GI issues. So the other important thing about GI issues are nutritional disorders, because a lot of children are very picky about what they eat. And so I think it's important to talk about vitamin C and vitamin D. Vitamin C I'm talking about because if you have a child who doesn't eat fruit, it's really important that you supplement. We had another child who stopped walking, who got the same x-rays and the ultrasounds, and nobody could figure out why she had stopped walking until a smart pediatric resident said, let's do vitamin levels. And the child had scurvy, which is an old-fashioned disease that the sailors used to get when they didn't have enough vitamin C. And so she was treated with vitamin C, and 2 weeks later she was walking again. And vitamin C deficiency causes a lot of bone pain, but she couldn't tell us she had bone pain. I think vitamin D is also very important because a lot of children aren't getting a lot of exercise. And we want to make sure that they don't have osteoporosis or weak bones when they get older. And so I think it's very important that each child who's not spending a lot of time in the sun, and certainly in this heat we're not, and up north in Boston where I live, most of us are probably vitamin D deficient in the winter. So I think it's really important that all the kids are supplemented with vitamin D. And you can talk to your pediatrician or internist about the amount, but the FDA recommended amount, which is 400 units, I think is not enough. So, and similarly, if your child is on a lactose-free diet, they're probably, some of the, like the almond milks and the soy milks, some of them have vitamin D and calcium added, and some of them don't. So you have to read the labels really carefully, and if your child isn't getting supplemented, then you should really supplement them. And you have to look at the vitamins carefully also, because the vitamins will say that they have vitamin D and calcium in them, and then you look at the gummy, and the gummy, you need to take 5 gummies to meet the FDA requirement. And so that can be a problem. And then in children who are non-ambulatory and are used to getting food as rewards, obesity can be a problem, or the child who's on a medication like risperidone, or that can be another problem. Okay, so now I have, my video didn't work, so I'm going to just try to minimize. And now I need my AV help because I can't find the cursor here. I wanted to show you a video of a child who had a unique behavior which we couldn't understand. Oh, you found it.
Just play it.
Yeah. So, okay, so I'll still tell you. So she had a unique behavior which we spent a long, long time trying to figure out what it was. And hopefully it's going to show up here. But maybe it won't.
I'm going to have to close your...
Close my presentation?
Yeah.
Okay.
Let me try that.
There.
Oh, it doesn't like it.
Oh, well. Okay. So I have to be an actress now. So she's lying down, trying to do her little desktop work, and she has a bunch of head drops, which look like seizures. Oh, you can't hear me? So she's lying down and has a bunch of head drops, which we think as neurologists are often seizures. So she got I think 3 or 4 EEGs done, including an overnight hospitalization where she had an EEG. And we couldn't figure out what it was. And then what happened is after she'd have these head drops, she'd have these very unusual dystonic movements where she'd like make movements like that, and oh, good, we have it. Okay. So she's doing her desktop work there with someone and with her therapist. And hopefully you'll see the head drops soon. Yep, there they go. So that can often be the sign of a seizure. And because I'm a neurologist, and actually this girl was treated by one of my colleagues who's a neurologist, we thought it was a seizure. And it kind of looks like a seizure, but then what happens is she has these very bizarre movements that are a little bit of dystonia, and we just couldn't figure out what they were. So we happen to have a gastroenterologist in our clinic who comes because there's so many kids with GI issues. It was easier to have them come out to us where the kids were comfortable. And he took a look at it and he said, you know, it's funny. I talked about this before, Sandifer syndrome, the syndrome where babies have reflux and they arch their backs and they turn their heads. And he said, let's put a pH probe down and see if she has reflux. And sure enough, every time she had one of these funny behaviors, her pH would drop. And so she was having reflux. This is reflux. It's not epilepsy, it's not dystonia, and it was treated with reflux medicine. So I just show it to you to say that not everything looks like you think. And it's really important we can switch back. It's really important to think of other things. And GI issues are really common as a problem and can present with reflux. And we had another child who wouldn't go to sleep and was having horrible behaviors around going to sleep. And she also had reflux and wouldn't lie down. And she always wanted to sleep sitting up, and of course, we tell the families, don't let your children sleep sitting up. And in this case, she was doing it to protect her pain. So it's always a little painful when you've been telling people the wrong thing. Okay. So vision and hearing. When a child doesn't see as well, then sometimes their behaviors change. And so it's also important just to think about vision and hearing. So in children with autism, 40% have vision problems, 29% have refractive errors, so they need glasses, and 20% have strabismus, which is when one of your eyes is just looking, they're not, like this little boy here. Oops. There, whose eyes are not quite straight. And amblyopia is when actually one of the eyes gets weak from that. Wearing glasses, as you may know, is a problem because they don't like the feeling of it. Fluorescent lights can be a problem. And then hearing and is also very important because if a child has recurrent ear infections, they might not hear properly, and then they start acting out because they're not hearing what's going on. So ear infections are a problem, and hearing loss is a problem in children with autism and PMS. So other medical issues to think about that can be a reason for behaviors. So drug reactions. I had one child that actually broke her nose with self-injurious behaviors, and we could not figure out what it was, went through all her medicines, and then her mother added as an aside, oh yeah, I also put her on a medicine for her allergies, but that's over the counter and it's safe. And we stopped that medicine, and she stopped her self-injurious behaviors. So even things that you might think are really safe sometimes can cause a bad reaction, so think about that. So endocrine issues, we know that hypothyroidism can occur in children with PMS, and that can, if a child is hypothyroid, their brain doesn't develop as well, and they can become irritable or sleepy, and so we think about that. And then I always mention premenstrual syndrome, the other PMS, because unfortunately our girls are not spared from that in adolescence and adulthood. And then adolescence itself, our children are not spared from that, and that can make kids very irritable. And then urinary tract infections are the other thing to think about. So as I said, I'm not a psychiatrist, but I'll just touch on the comorbidities that are really important to address. Hyperactivity and impulsivity. So a child can be more hyperactive and impulsive because they're not sleeping. So, or because they have pain or some other medical issue going on. Irritability is the same thing, and aggressive behaviors, as I mentioned, repetitive behaviors, as I mentioned. As you all know, mood disorders and bipolar disease can also be a cause of regression or behavior changes. And so if you're noticing that, it's important that you rule out the medical issues and make sure there's nothing medical going on, and then that you get treatment from a psychiatrist or psychopharmacologist. And depression is another one, and that can be really life-altering for a child. And sometimes the depressions are more biological, and sometimes they might be related to something that happened in the family, like a dog dying or a brother going off to school. So, because changes in the environment can have a profound impact on a child. So that's something important to think about. And anxiety, as I've mentioned before. Catatonia, we don't see that very often in pre-adolescence, but in children who've become adolescent, we sometimes see that. And I personally don't treat it usually, but the psychiatrists do. It's something that we've been talking about in our consultation group quite a lot because it's very difficult to treat. So I'm going to take questions at the end because I'm almost done. And I don't know, let me see what time it is. Yeah. So I have some other tips for you guys. And these are for you as parents, but also for your prescribers. So the first thing is figure out what you're treating as much as possible before you're starting a medicine to treat. Like giving melatonin, for example, to a child who has anxiety isn't going to work. Because if they have anxiety about going to sleep, the melatonin's going to do nothing. Because they're so anxious, they're not going to fall asleep until their anxiety is relieved. And then use the medicine as a part of a comprehensive treatment program. So giving a pill without helping to treat behavior and making sure you're not reinforcing the behavior in some way doesn't work. You have to also make sure that you're the whole team, the teacher, the behaviorist, and everyone else is working with you together. Always weigh the risks and benefits of starting a new medication, including the side effects, and think about drug-drug interactions. Because many of the kids are on multiple medications, and we always need to make sure that everyone's thinking about the side effects and the drug-drug interactions. Obtain informed consent from a parent and legal guardian, and when possible, assent from the child. So I've had many children, I've prescribed the medicine for them, and then the mothers come back a month later and say, well, we never started it because my son didn't want to take it. And that makes me feel really bad because they wasted a visit coming in to see me, and because I didn't do my job and made sure that the child would buy into starting a medicine. And then whenever possible, start one medicine at a time. That helps us to figure out if the medicine is working. If you start 2 at a time, then you never know whether which one's causing the bad side effect or which one's helping. So 1 at a time. And then start low and go slow, especially with psychiatric medicines. Like we'll start with half of the smallest pill often. And you know, the medicines were tested in children, and their doses were tested in children and adults who are typical and have typical brains. And because the PMS kids don't have typical brains, sometimes they need a much lower dose, and sometimes the medicine that we think will work for them doesn't. So then monitor carefully for the response and side effects. And if the medicine is clearly making things worse, don't wait 2 months until your next doctor appointment. Call them up and tell them that things are worse so that nobody's suffering. And then again, involve the multidisciplinary team members, the family, the school, the therapists, to help monitor also. So when I put a kid on medicine, I'll tell the family to tell the teachers that your child is going to start a medicine. You don't have to tell them which medicine it is. You don't even have to tell them when you're starting it. In fact, I like to have the family have a week without the medicine. They say to the school, we're starting a new medicine, and then for 1 week they don't start. So that way you kind of have your baseline, and then you start the next week. And then always consider the biopsychosocial and the developmental context of the child. So making sure you are aware of the age and abilities of the child. And then, now I'll say it again, patients with PMS do not always respond to medicines the same as neurotypical children do. And this is important for your doctors to know, because stimulants like Ritalin and Adderall don't always work the same way they do. Sometimes they make children more agitated, and they need to understand that. So I love this slide. I'm very grateful to the people who made it. It goes, and I know you have it in your booklets, and I'm just showing it here because I think you should take it with you to your doctors and make sure that they're looking and thinking about all of those medical issues that can impact a child with PMS. So I'll just tell you a little bit about my clinic. I work at the Lurie Center at Mass General, and our goal is to advance knowledge of autism spectrum and related disorders and to translate discovery into exceptional care. We're a multidisciplinary clinic for children and adults with PMS and autism and developmental disabilities. So we see children, as young as 6 months or 3 months, and all the way, I have a couple patients in their 50s. So we have pediatric neurologists, child psychiatrists, and adult psychiatrists. And we just hired an adult psychiatrist who's there just for parents. She's already busy. It took about 6 months. And she has some groups, which is kind of cool, groups for parents, and she's starting a group for fathers, which I think is a great idea. We have developmental pediatricians, a gastroenterologist, a geneticist, neuropsychologists, nurses, family support, education consultation, and a behaviorist who does consultation. And we're work with another hospital called Spalding Rehabilitation Center. So they're on the other side of our building. We're out in the burbs, so parents don't have to pay for parking, and sometimes we can see kids in the parking lot if they're afraid to come in. So that's about it. I'm happy to answer questions. You have my email if you want to ask me a question. I always warn people that I can't always answer emails the same day because I get busy. All questions are good ones. So if you have any questions, I think someone's going to help.
Our son falls asleep. He's nonverbal, but you can be on the lower floor in the home, and he sounds like he's having a party at 2 to 3 times a night, and then he's asleep when we get him up in the morning, but I just wonder, he's very loud and, I don't know if it's restless, but it just seems like you would think he was awake and you go up and he's not.
So it might be worth actually getting a sleep evaluation to make sure that he's sleeping properly. He may have restless leg. And children who don't get enough iron can get restless leg syndrome. So it's very easily treated in some children, but it might be impairing his sleep, especially if he's sleeping in the morning. He may not be getting what sleep he needs during the night. So
you mentioned hormones.
Oh yeah.
So our daughter got her period for the first time last month, and massive aggressive behaviors.
Yeah.
And we started on the depot shot, and the doctor's not worried because she's no longer getting her period, but she doesn't think there's anything we can do to help with the hormones. We don't know what to do. So you should talk. So we have some families or some children who go on medicines when they're about to, is it all the time or is it just like PMS? It starts a couple days before she's due for her period, but she doesn't actually get her period anymore because of the depot.
Right.
And it lasts for several days throughout her period. So I'd say there's about 10 days, 12 days where she's just, attacking everybody.
Yeah, so you should talk with a child psychiatrist and they can help her with some medications for that.
Okay, because she was on risperidone previously, and we completely backed her off because she was doing so great, and now, and we know it's hormonal related, obviously, but Right.
I mean, we're just stumped. We don't know what to do.
Yeah, yeah, you have to do something because it's horrible for her also.
Yeah.
Yes.
Our daughter is 48, and she's had lots of language challenges over the years, and lots of behavior problems. However, when she became 16, she got her period and would become manic for a year.
Oh my.
And then she'd stop for a little bit, and then it would start again. However, praise God, she hasn't been manic for 2 years, and we have never thought about the relationship between periods and that mania. Have you had any experience with older PMS children, women?
No. I'm
So-
sorry.
Okay.
So 20 is as old as I've gotten so far.
Right, so we may take a look at that then.
Yeah, but so we're going to learn more because more adults are getting diagnosed because they're having the genetic testing. So we're hoping in the next couple years we'll be able to get more information and also just personal experience.
And with that, mania would become great weight loss. So going from a size
Yeah.
12 down to a size 4.
Yeah. Wow.
And every size in between. I've got suitcases full of clothes. But now she's stable. At that. Her weight is 100 and 30, 40. So very stable.
Yeah.
But that whole concept of periods we hadn't gone into that. So.
Well, and hormonally, she may be not making as many. I'm not an endocrinologist, but I know there's one here.
Right. Okay.
So that may be going on.
Okay, Miss. So have you had any suggestions of who we should look at? Just an endocrinologist?
Do you have any thoughts?
I've never thought about that relationship before.
Yeah. Yeah.
No.
I mean, if you've been 2 years without it, then I would be hopeful that you might be done with that phase. And do you go to a psychiatrist for her?
Psychiatrists have never seen anything like her. Like we're in
I know, but
Toronto.
did they give her medication?
Oh yes, but the medication would make it worse.
Worse. Okay.
So we had to stop. Then we had to gradually get rid of the medication because it made her totally manic. Yeah.
Right.
Really, really
Right.
bad.
Right. I will ask around.
All right. Thank you.
Yeah.
Okay.
My daughter also started having, for lack of anything else to call it, we call it crisis, when at onset of puberty, when that's when her psychiatric symptoms would appear. She could be floridly psychotic, sometimes delirious. Sometimes we had mania. Sometimes we had total withdrawal.
Right.
And we gave, she is on depot shots. We to shut her periods down. Normally that is given every 3 months.
Right.
We've had to give it every month to shut things down completely. And for our daughter, when she would have these crises, afterwards she would not return to baseline. There are some downside effects of depot,
Right.
but we had to make the choice on whether we would try to preserve her skills or we would shut the periods down.
Right.
Because she had GI issues and intestinal dysmotility and possibly absorption issues, they were afraid to give her oral birth control. None of the antipsychotics worked for her. They caused more serious problems.
Yeah.
SSRIs caused the mania to be worse. Other types of mood stabilizers did not work. None of the anti-seizure medicines worked. So we've had a tough time.
Right.
Nobody knows why it works, but D10 IVs have worked to
I'm sorry, what's D10?
10% dextrose.
Oh.
has helped. They thought she had mitochondrial disease. She's now 44 years old. She was diagnosed with point mutation in 1942, not 1942, when she was 42, by whole exome sequencing.
Wow. So I think what you're describing is that there are a lot of medical issues that many people see in their children, and that there can also be two distinct problems, like a mitochondrial disorder as well as PMS.
Well, no mitochondrial gene was found.
Oh, there was none.
But her neurologist that's followed her for 25 years says that she clearly has mitochondrial dysfunction.
Yes.
She was diagnosed with mitochondrial disease at Johns Hopkins.
I see.
Because of excretion of alanine, glycine, and alpha-ketoglutarate in her urine.
Yeah.
And she had excess lactate in cerebral spinal fluid,
Okay.
which are not PMS findings, but they are also not considered diagnostic markers at this point for mitochondrial disease.
Right. Well, someone was thinking outside the box that thought of doing the dextrose infusions, so I'm happy that worked for her.
Well, at first it was to admit somebody to the hospital when you didn't know what was wrong, if you put them on an IV, they could be admitted. And then they tried the 5% dextrose, and at first, that would turn things around. Then it became less and less effective. It would be sometimes she would get better a week after the onset, after you were home from the hospital and the acute phase was over. Then it got to the place that wasn't effective, and we went to the D10. That's marginally effective, but it changed the incline of the line that describes her loss of skills from something like this to like this.
Right.
Still, there's a decline. We still have that, okay? She has dementia-like presentation now. And if you would superimpose a sine curve over that, she would have peaks and valleys on this decline.
Right. Well, I think maybe we can talk with people about next year, talking about the role of puberty in behavior, and maybe we can try to figure out if we can get somebody over who can talk about that to families, and also this progressive decline as people get older. That's a problem that we are trying to figure out.
Thank you.
Yeah.
Has there been, in your experience, an increased incidence of high ammonia levels with people with PMS from Depakote? Because my daughter has had toxic ammonia levels of like 130 on Depakote. We've had to taper her off. The ammonia level has stayed, unfortunately, a little bit high. And I read some literature, being a nurse, I kind of researched, that genetic syndromes apparently had a higher incidence of high ammonia levels, and I was wondering if you have had that experience with PMS?
So I haven't, but I will keep my eyes out for that now.
Okay.
When I have young children or children with a known genetic syndrome, I'll often put them on carnitine as well, because it was thought that carnitine would help protect. So
she's
I
on
do that.
carnitine now, and of course the lactulose.
Yeah. So, but yeah, so I haven't, but I will keep an eye out.
Do you use acetylcarnitine, or do you use the levocarnitine?
I use the levocarnitine that they get from the pharmacy. Any other questions? Well, thank you for listening. I think there were some announcements that needed to be made also, right?
Sure. Don't forget to evaluate the session on the app. We have a link to the not only session evaluations, but conference evaluation, overall evaluation too. Your feedback is real important as we look ahead to 2020. So please fill out those evaluation forms. And let's give a nice hand to Ann Neuer. I wanted to remind, too, that there are still one-on-one consultations for genetics, communications, and toileting.